Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share some very useful tips with you which may prove handy in your line of duty. So I welcome you to part 89 of our Pharmacotherapy MCQ series, which majors in basic oncology. Welcome. The first question reads, Mr. M.O.W., a 63-year-old male patient, is scheduled to receive thiotepa and cyclophosphamide at your oncology clinic for an allogeneic hematopoietic stem cell transplant. He has a past medical history of myocardial infarction, hypertension. He's had a blood clot before, and he suffers from type 2 diabetes mellitus. So my question to you is, which of the monitoring parameters listed below would you consider the most important for cyclophosphamide therapy? Would it be an abdomen CT scan, plasma calcium, electrocardiography, or an HbA1c? I'll give you 10 seconds to choose the correct answer. Electrocardiography it is. Now, I would like to comment that high-dose cyclophosphamide, that is over 100 to 200 milligrams per kilo within 48 hours, is typically given in patients undergoing hematopoietic stem cell transplant. Now, patients receiving high-dose cyclophosphamide are at an increased risk of non-hematologic toxicity, which includes hemorrhagic cystitis, cardiac toxicity, GI toxicity, and even SIADH. Now, cardiac toxicity is a dose-limiting toxicity of cyclophosphamide. Now, Mr. M.O.W. already has a history of myocardial infarction. Therefore, it's imperative to have a baseline cardiac function assessed through an ECG, for example. Now, the HbA1c is important for patients with the history of diabetes mellitus, but not for cyclophosphamide. And then plasma calcium and the CT scan aren't imperative for cyclophosphamide toxicity monitoring. So all those many ones justify why C, electrocardiography, is the best answer to this question. Let's move to the next question, please. And it reads, your medical oncologist has scheduled Mrs. BTM, who happens to be a 66-year-old female patient with confirmed metastatic breast cancer, to receive paclitaxel and trastuzumab chemotherapy. So my question to you is, how would you rate this regimen's risk for causing emesis or chemotherapy-induced nausea and vomiting? Is it minimal, meaning below 10%? Is it high, meaning above 90%? Is it low, meaning 10 to 30%? Or is it moderate, meaning 30 to 90%? I'll give you 10 seconds to choose the correct answer. It It is low risk, meaning 10 to 30%. Now, trastuzumab, marketed as Herceptin, like most monoclonal antibodies, is minimally emetogenic. The taxanes, such as paclitaxel, are also considered low risk. Now, since BTM is above the age of 50, her risk is less than those aged below 50. So all those many ones justify why I classify this case as a low risk, meaning 10 to 30%. Let's move to the next question, please. And it reads, your medical oncology starts Mr. PLR, a 34-year-old male patient with confirmed testicular cancer on bleomycin, etoposide, and cisplatin, which is abbreviated as BEP. My question to you is, which of the statements listed below is appropriate regarding this particular clinical scenario? Is it true that cisplatin doesn't cause delayed nausea and vomiting? Thus, Mr. PLR should receive ondansetron plus dexamethasone before chemotherapy, with dexamethasone continued on days 2, 3, and 4? Or is it true that cisplatin is considered highly emetogenic? Thus, Mr. PLR should receive fosaprepitant plus olanzapine before chemotherapy, with olanzapine continued on days 2, 3, and 4. That cisplatin can cause delayed nausea and vomiting. Thus, Mr. PLR should receive fosaprepitant, palonosetron plus dexamethasone before chemotherapy, with dexamethasone continued on days 2, 3, and 4. Or lastly, is it true that cisplatin is considered to be low to moderately emetogenic? Thus, Mr. PLR should receive fosaprepitant plus ondansetron plus dexamethasone before chemotherapy, with dexamethasone continued on days 2, 3, and 4. I'll give you 10 seconds to choose the correct answer. So C is the correct answer. Now, cisplatin is considered highly emetogenic and is also the classic agent that causes delayed nausea and vomiting, which occurs over 24 hours after chemotherapy and peaks about 48 to 72 hours after the administration. Now, according to the NCCN guidelines, any of the following 3 drug antiemetic regimens can be used. When given concomitantly with an NK1 antagonist, there is no preferred 5-HT3 antagonist. Therefore, palonosetron and ondansetron are interchangeable when given in combination with fosaprepitant. So the regimen A may include, for example, an NK1 antagonist. You can choose from a prepitant, either oral or IV, single dose, or fosaprepitant, IV, single dose, or the co-formulated netupitant and palonosetron orally once a day, or the co-formulated fosnetupitant and palonosetron IV as a single dose, or alternatively rolapitant orally as a single dose, and that can be combined with a 5-HT3 antagonist such as dolasetron orally one single dose, or granisetron, which can be administered subcutaneously, IV, or orally as a single dose. It can even be administered transdermally, or you can also opt for ondansetron orally or IV as a single dose, or even palonosetron but as an IV dose, and that can be co-administered with dexamethasone either orally or IV as a single dose. Regimen B can be selected from olanzapine 10 milligrams orally as a single dose, alongside palonosetron IV as a single dose and dexamethasone orally or IV as a single dose. Now, regimen C can include olanzapine orally 10 milligrams as a single dose and an NK1 antagonist. You can also choose, like in the above case, from aprepitant either orally or IV as a single dose, or fosaprepitant as a single IV dose, or the co-formulated netipitant and palonosetron as a single dose orally, or the fosnetipitant co-formulated palonosetron IV as a single dose, or rolapitant orally as a single dose, and 5-HT3 antagonists such as dolasetron, granisetron, or ondansetron, or palonosetron, single doses. And I would just like to add that if aprepitant 125 milligrams is administered orally as a single dose on day 1, it should be followed by 80 milligrams orally on days 2 and 3. And remember, if a combination product such as netipitant, palonosetron, or fosaprepitant, palonosetron is used, then no further 5-HT3 antagonist is needed. That is to say, do not add ondansetron or granisetron to them. Now, if dexamethasone 12 milligrams is chosen either IV or orally, and that is administered on day 1, then it should be followed by 8 milligrams either IV or orally on days 2, 3, and 4. Now, if olanzapine 10 milligrams orally is administered on day 1, then it should be followed by 10 milligrams orally on days 2, 3, and 4. Now, if fosaprepitant plus olanzapine plus ondansetron plus dexamethasone are not appropriate antiemetic regimens for highly hematogenic regimens, I'd just like to say they are not. For highly hematogenic chemotherapy, such as a case where a patient is receiving cisplatin, the NCCN guidelines recommend a variety of 3 drug regimens that target different receptors to prevent nausea and vomiting. So it's I know it's tough, it's confusing, but I would advise you to read the guidelines and digest all that I've tried to explain in a few words. Let's move to the next slide, please. And the question reads, POS, a middle-aged cancer patient, is receiving panitumumab. So my question to you is, which laboratory values should the oncology team managing this particular patient monitor closely? Would it be the LFTs? Would it be CBC and urinary protein? Would it be magnesium or CBC? I'll give you 10 seconds to choose the correct answer. So magnesium it is. Now, since panitumumab is directed towards EGFR, it doesn't directly cause blood count disruptions at all. Now, the only abnormality that has been noted is approximately 30% will develop hypomagnesemia. However, 7% developed significant hypomagnesemia from studies. Now, some patients will develop both hypomagnesemia and hypocalcemia, so watch out for those electrolyte disturbances when managing such a patient. Let's move to the next question, please. And it reads, Mr. DKN, a 57-year-old male patient with non-multiple myeloma, is admitted for a scheduled administration of high-dose melphalan chemotherapy followed by an autologous hematopoietic stem cell transplant. He has a history of poor dentation, and the oncology nurse seeks to know of different strategies to minimize stomatitis from the melphalan. My question to you is, which of the options listed below would be the best to prevent or to minimize mucositis? Is it A, would you choose to have Mr. DKN use sucralfate 1 gram mouth rinse 4 times daily, or would you have Mr. DKN suck on ice chips before, during the melphalan infusion, and for 30 minutes after the infusion ends? Or would you use the triple mix of diphenhydramine, nystatin and lidocaine before meals? Or would you keep his mouth clean with multiple brushings and flossings throughout the day? I'll give you 10 seconds to choose the correct answer. I would have Mr. DKN suck on ice chips before, during the melphalan infusion, and for 30 minutes after the infusion ends. Now, using cryotherapy, that is, ice chips, may significantly reduce the severity of mucositis in patients receiving high-dose melphalan. Now, use of prepared concoctions such as the triple mix and sucralfate are ineffective in prevention of mucositis. So that makes answers A and C wrong. And I would like to emphasize that keeping the patient's mouth clean is important, but using brushing and flossing may damage the gums and lead to an infection or even severe mucositis. Now, using the soft form to thread style is a device called the soft form to thread. It's a device that is useful in such people, is the best option to clean the mouth without damaging the gums. It's very gentle, and avoiding alcohol containing mouthwashes is also prudent, since such alcohol containing mouthwashes may dry out the mucosal tissue, leading to mucositis, so avoid them at all costs. And lastly, using a salt and baking soda mixture is ideal to use in multiple times daily to keep the mouth clean. It would work well for this particular patient. Let's move to the next question, please. And it reads, which of the following is the primary nonmyeloablative dose-limiting toxicity observed when busulfan is administered as a transplant preparative regimen? Is it hemorrhagic cystitis? Is it sinusoidal obstructive syndrome? Is it graft versus host disease, which we abbreviate as GVHD? Or is it cardiotoxicity? I'll give you 10 seconds to choose the correct answer. Sinusoidal obstructive syndrome it is. Now, busulfan is well known to cause SOS, or even veno-occlusive disease of the liver. Now, symptoms of SOS include weight gain, elevated bilirubin, painful hepatomegaly, and even edema. Now, the reason why busulfan causes this adverse effect is unknown, but the results can be deadly, so watch out for them. Now, cardiotoxicity and hemorrhagic cystitis are seen with high doses of cyclophosphamide, not busulfan. And then the graft versus host disease is a result of the newly transplanted allogeneic hematopoietic cells attacking the host. Let's move to the next question, please. and it reads, Mr. PLT, a 60-year-old male patient with confirmed metastatic lung cancer, presents to your oncology clinic with progression of his lung cancer on platinum-based combination chemotherapy. The medical oncology resident is considering initiating PLT on erlotinib but isn't sure of its mechanism of action. So my question to you is, which of the following outlines the mechanism of action of erlotinib? Is it true that erlotinib inhibits EGF's activity by binding to EGFR and therefore preventing EGF interacting with EGFR? Or is it erlotinib inhibits EGF's activity by binding to EGF and therefore preventing EGF interaction with EGFR? Or is it erlotinib inhibits EGF's activity by preventing phosphorylation of intracellular domain of EGFR? Or is it D, erlotinib inhibits epidermal growth factors EGF's activity by prevention of phosphorylation of extracellular domain of epidermal growth factor receptor EGFR? I'll give you 10 seconds to choose the correct answer. So C is the correct answer. Now erlotinib is a TKI, that's a tyrosine kinase inhibitor. All TKIs work intracellularly and prevent autophosphorylation of receptor and further signal transduction. And there is no phosphorylation activity that occurs extracellularly, so that makes answer D wrong. And there are no monoclonal antibodies that may inhibit growth factor activities by binding to a ligand or growth factor like bevacizumab does, so that makes B wrong. Or binding to the receptor on the extracellular domain like cetuximab does, so answer C is also wrong. I would just like to add that erlotinib, gefitinib, afatinib, and osimertinib are all TKIs that inhibit autophosphorylation of the intracellular domain of the EGFR. Let's move to the next question, please. The next question reads, VAS, a 47-year-old patient with confirmed breast cancer, has stage 3 chronic kidney disease with a creatinine clearance of approximately 40 ml per minute. My question to you is, which of the antineoplastic agents listed below are predominantly cleared by the kidneys and requires renal dosing in VAS's case? Is it Gemza, gemcitabine, ixabepilone, Exempra, and epirubicin, Elens? Or is it liposomal doxorubicin, Doxil, paclitaxel, Taxol, and vinorelbine, Navelbine? Or is it Zeloda, Platino, Halaven? Or is it Taxotere, mitoxantron, and carboplatin? I'll give you 10 seconds to choose the correct answer. So it would require renal dosing in the case of capecitabine, Zeloda, alongside cisplatin, platinum, and eribulin, Halaven. Now, just like to add that capecitabine, platinum agents such as carboplatin and cisplatin, and even eribulin are all agents used in metastatic breast cancer that require dose adjustments in patients with creatinine clearances below 50 ml per minute. Now, all the other agents are primarily cleared by the liver. Just like to remind you that gemcitabine is cleared renally. However, there are no dose adjustments recommended for mild to severe renal disease when using GEMS. Let's move to the next question, please. And it reads, Mrs. PST, a 67-year-old female patient, presents to your hospital with severe abdominal pain. Her chief complaint includes bloating and diarrhea for the last 60 days, which is unrelieved by OTC medications that she had purchased, lack of appetite, hot flashes. Now, your lab at the hospital reports her cancer antigen 125, what we abbreviate as CA125, as 1052. So my question to you is, which of the symptoms listed below is suggestive of ovarian cancer? Is it diarrhea, poor appetite, dysuria, hot flashes, and elevated CA125? Or is it abdominal pain, increased urinary urgency, poor appetite, and elevated CA125? Or is it abdominal pain, diarrhea, vaginal bleeding, and elevated CA125? Or is it weight gain, diarrhea, hot flashes, and elevated CA125? I'll give you 10 seconds to choose the correct answer. So it would be abdominal pain, increased urinary urgency, poor appetite, and elevated CA125. Now, historically, ovarian cancer was called the silent killer, since it was considered an asymptomatic disease. Now, most patients presented with advanced disease, which is less treatable and is associated with poorer outcomes. An ovarian cancer symptom index tool was developed to help identify women at risk of having ovarian cancer by recognizing specific symptoms that were significantly associated with the disease, such as pelvic pain, abdominal pain, urinary urgency or frequency, increased abdominal size or bloating, and poor appetite or early satiety, which best reflects answer B. Now, the sensitivity of this index is high in those with advanced stage disease, 79.5%, versus early stage disease, which is around 56.7%. Now, the specificity was 90% for women above the age of 50 and 86.7% for women below the age of 50. Now, the CA125 is also frequently elevated with ovarian cancer, just for your information. Now, the constellation of symptoms suggestive of ovarian cancer, I'll repeat myself, include pelvic or abdominal pain, urinary urgency or frequency, increased abdominal size or even bloating and difficulty eating or feeling full when they are present for, say, less than a year and occurred at least 12 days per month. Now, the incidence for the sleep of ovarian cancer increases with age, and the median age at diagnosis is 63 years. Now, more than 70% of patients present with advanced disease, unfortunately, when the prognosis is already poor. Let's move to the next slide, please. And the question reads, Mrs. ZST, a 60-year-old female patient who resides in Boston, USA, was diagnosed with early-stage hepatocellular carcinoma 2 months ago. She has a past medical history of hypertension, Rheumatoid arthritis, she's an IV drug abuser and she's been doing that for 10 years, and she smokes 1 pack weekly. She's been doing that for 25 years. She has a social history of taking 4 beers daily at dinner time, and she takes more fast foods 5 days a week. A CT scan of the liver was negative for cirrhosis and ascites. Now, multiple areas of the hepatic masses were appreciated. So my question to you is, which of the factors listed below is the most likely to be associated with Madame ZST's hepatocellular carcinoma? Would it be alcohol consumption, aflatoxin exposure, hepatitis B virus, or hepatitis C virus? I'll give you 10 seconds to choose the correct answer. So hepatitis B virus it is. Now, risk factors for hepatocellular carcinoma include cirrhosis, hepatitis B viral infection, hepatitis C, excessive alcohol consumption, even obesity, diabetes can be an issue, non-alcoholic fatty liver disease, even inherited liver disorders, aflatoxin exposure, and Asian race, especially males above the age of 40 or females above the age of 50, Black or African Americans, both male and female, with hepatitis B are also at an increased risk of developing hepatocellular carcinoma. Now, ZST's history of IV drug abuse puts her at an increased risk for both HCV and HBV. Now, just like to say that about 60 to 80%, close to 90% in the US of HCC patients have underlying cirrhosis. Now, with the lack of cirrhosis, according to the CT, in the case of this patient ZST, HCV and alcohol consumption are less likely, whereas 30 to 50% of HBV carriers develop HCC without underlying cirrhosis. So it's more likely a case of HBV than HCV. Now, aflatoxin, which is a product of aspergillus, is found in various grains and is least likely to cause this lady's HCC because she lives in Boston, which has a predominantly cold weather. Now, based on her diet, she's less likely to have excessive consumption of aflatoxin. Now, HBV is the most likely cause of her hepatocellular carcinoma. Now, just like to repeat that risk factors for HCC include, in HBV carriers without cirrhosis include active viral replication, high HBV DNA levels, and even a family history of HCC. So just remember that. Let's move to the next question. It reads, your oncology team is managing a 26-year-old male patient with relapsed Philadelphia negative ALL. They have initiated him on blinatumomab. So my question to you is, which of the adverse drug effects listed below is associated with blinatumomab therapy? Is it tremors, headaches, DIC, or all the above? I'll give you 10 seconds to choose the correct answer. So D is the correct answer. Now, blinatumomab is a bispecific T-cell engager, abbreviated as BITE, which targets CD19 on B cells. It has a black box warning for life-threatening cytokine release syndrome, which includes fever, headache, nausea, asthenia, hypotension, increased transaminases, elevated total bili, even DIC. It can also cause neurotoxicity, which can manifest as tremors, headache, and even confusion. Now, patients receiving blinatumomab should be closely monitored for signs of cytokine release syndrome and neurotoxicity. Now, for patients who experience cytokine release syndrome and neurologic toxicity, blinatumomab may need to be withheld or discontinued depending on the grade of toxicity. Now, if the infusion is interrupted for 4 or more hours, patients should be pre-medicated with dexamethasone 20 milligrams 1 hour prior to restarting the blinatumomab therapy. Just as a by the way. There you have it, ladies and gentlemen, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, and to share it widely with your peers, and to leave any comments. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. I thank you very much for viewing and for listening to this video, and I sincerely appreciate your partnership, your continued support, and your very kind collaboration. And I look forward to interacting with you in part 90 of our MCQ series. Thank you very much.